Okay, so today is October 20th, 2020. We're going to be covering the back. Next class, we're going to be reviewing the back again and covering low back and hip next class as well. So we'll cover the back today, and then again, more of the back next week, as well as the hip. So back pain is probably going to be the thing that, unless you have a specialty, it's probably going to be the thing that people come in to see you for the most. And, you know, again, I know we're talking a lot about very specific types of treatments and very specific ways of assessing people on a physical level, but I don't want you to discount the mental, emotional, and spirit level. You know, just the other day, I did IDs on somebody and it made a tremendous difference in their pain. So you don't want to discount those. And I always include those treatments as well. IDs, EDs, AE, you know, look for HWs, look for CBGB blocks, although they're rare. Check Akabani's 2-3 times. Exit entry blocks. These are all very important. So most of what I experience people in the back are kind of two things. People are experiencing tremendous overwhelm. That is, they're you know, working really hard at trying to get everything done, to meet all their obligations, to meet all their responsibilities, and they're doing it in a way that leaves them feeling like understrong, as it were, right? They feel weak. They feel maybe impotent to create some kind of change, right? Again, water feeds wood. They might be under a tremendous amount of fear or nervousness, which could be left over for some trauma that they've experienced earlier in their life and is now showing up because the metal has become weak. And that's the second kind, where people, their metal is very weak. The metal element is very weak. The correspondence is that our alignment with the lung and the large intestine have become compromised, right? Maybe a lot of grief, maybe a lot of loss. And these days, especially, you know, it affects the heart as well, because there's unfulfilled desires, right? That strongly affects the heart. But, you know, there's a different quality of grief that we don't often talk about, which is grief over the loss of things that really never were, that never came to fruition. This isn't the life that I had imagined for myself. It's like the loss of possibility, the loss of people's dreams. As they get older, you know, there's less possibility in our minds about life in front of us, although we know that to some degree that is accurate. But also, to some degree, that's a self-imposed limitation. And so there's a lot of men, especially, who grieve over like the life they wanted to have, but didn't have. Maybe their kids turned out in ways that were challenging for them. Maybe their kids had like a lot of physical health problems, or their spouse developed physical or mental, emotional health issues, right? You see this a lot in married couples for a long time. At some point, you know, maybe something happens and a spouse starts to suffer from mental illness or depression like they never had before. Their bodies aren't responding to life the way they did before. You know, it's like, wow, I used to be able to like do anything I want. Now I garden for an hour and I'm really sore, or worse, right? So metal obviously tonifies the water, right? Lungs, kidney, large intestine, bladder. So, you know, there's, especially these days, there's a lot of, as always, but more so now, I think lately, there's kind of a capitalizing on a quality of fear, and people are buying into it because their diet and their busyness don't give them the capacity to be fully present enough to question the information that they're given through the various sources of media that they're exposed to. No one stops to say, I wonder if that's really true, or if that were true, like, let's play this out. Like, you know, this person said that. So if that were true, like, that means this I would probably see more of this in the world, but I actually don't see that. So maybe that's not true. And so, you know, people are more and more losing their capacity to control their fear because their earth is so messed up by their horrible diets and their inactivity. And it creates a lot of damp phlegm, which obscures the mind and our capacity to think clearly and be thoughtful. So people are just more and more just reactive. And that weighs heavily on their chi system. It's very depleting. It's very stagnating. And as you know, pain comes from deficiency and stagnation. So I think one of the best things we can do is to tend to people's spirits, to help wake them up, to get the chi moving, to get the blood moving, bring chi and blood back to the brain, bring chi and blood back to the orifices, the sense organs, and help people wake up to how they're living their life as well as what they're doing with their bodies, to look at their mindset, to look at their belief systems, right? To look at what are the things that are weighing heavily on their nervous system, which weighs heavily on the water, particularly the bladder. And as we know, the bladder channel, it permeates the back, as well as the kidney. Like there is an internal branch of the kidney that goes up the side of the spine. So a lot of vertebral issues are going to involve the kidney as well. All right. So in your notes, I've given you a little bit, like in the second paragraph there, how are people overworking? Because, one of the things I loved about learning from Bob Duggan is like, you can live by reality or you can live by concept. And most people, unfortunately, live by concept. I should be able to do this. I need to be able to do that. Therefore, I should be able to do that. But that's killing them. It's disturbing their chi system. It's wearing their bodies down. And so they're living by shoulds and shouldn'ts. And that's overwhelming their system, which is leading to deficiency, which then leads to stagnation, which then leads to pain. So we have to help them look at what are their beliefs about how they're living their life, as well as, and this also figures very heavily right now, is our relationship to power. The kidneys are responsible for the creation of power. Skill and ability stems from it. So if you're powerless, how much skill and ability are you going to be able to manifest? Not very much. So this is something that people have to look at. We have a love-hate relationship with power in this country. We love it. We love powerful people. But then when they start to have beliefs that are different than ours, then, then we want to kill them. So.
That's a little extreme.
Is it?
It's not just a little, it's very extreme.
And it's not uncommon right now. It's so scary.
Look around. I mean, it's happening.
I think,
they just tried to kidnap the governor of Michigan.
I think that's the essence of our society. We live in a very violent society, and whether or not we want to, this is what a Buddhist monk told me one time. Each one of us has a responsibility.
Yes.
Whether we want to admit it or not, we're all responsible.
Yeah. Now, I'm not saying everybody out there has murder in their heart. That's not what I'm saying. But we all have a shadow. And I think that there's a point where I admit that I get sometimes where I get really triggered and I feel violent impulses move through me. I don't act on those impulses, of course. And then I also move the chi so it doesn't get stuck. So I'm, not dying of a heart attack at 55. Right. But, I've got Sicilian blood and it runs hot. So the point is we all have a shadow.
No carry permit for you. That's
right. No, that would be a bad idea. There would be a pretty wide swath of death behind me. But so the point is like the kidneys rule the shadow, right? That which has not manifested, that which is like dormant and potentially arising given the right conditions, right? And we have to explore that. And we carry a lot of that in our low back. We carry a lot of our shadow in our low back, and we carry a lot of our manifestations in our bellies, right? Like as goes the belly, so goes the mind. As goes the mind, so goes the belly. So, I've got sort of like more and more, I've got these patients coming in who are like 5'4", 250 pounds, horrible diet, don't exercise, over 40, terrified or angry, and in a highly reactive state. And then they wonder why their back hurts and their knees hurt and their joints hurt. And, you know, and they're looking for a pill. And I tell them I'm not selling them a pill. I'm selling them healing, and I'm going to help them heal. So, you know, a lot of people are on board with that. Some aren't. But this is, you know, the kind of the landscape that we're dealing with. You know, I wish I had the kind of practice where people were coming in for just like a little bit of spiritual openness, you know, like I wish they don't get those. Right. So, in your notes, I've given you a list of the bones and the muscles and the meridians. I've talked a little bit about how low back issues arise from a number of conditions, most commonly deficient kidney qi, with an underlying deficiency of kidney yin and or yang, or essence even. Essence is either a congenital issue or a very, 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 very chronic issue. Usually people who've had some kind of illness that have depleted them, or they're pretty advanced age and they've had a pretty tough life. I've talked about how to investigate the possibility of internal deficiency on page 2, either from inherited weakness or excessive emotions or overwork or some chronic disease, okay? So, you know, there's signs and symptoms that go with that are listed. I do a lot of channel work. So I do some Zongfu organ type work because I think, you know, obviously that needs to be functioning well for the qi, because the official lives in the channel. So, you know, the channel is not going to be healthy if the Zongfu organ isn't very healthy. So we have to work on that. And with the Zongfu work, I work predominantly with diet and herbs, as well as some acupuncture. Moxibustion, especially now that we're getting to the colder weather, is extremely helpful for any kind of kidney deficiency, with the exception of, but also can be used in some conditions of kidney yin deficiency, empty heat symptoms, which you get with a lot of women in their sort of like in the menopausal age, like around, you know, 40s, 50s, sometimes even 60s. Although it is showing up more and more now in men over the past 5 years, I'm getting a lot more guys with night sweats. Yeah. So either they're somehow ingesting a tremendous amount of estrogen through the plastics in their, you know, holding their water or food or things like that, or some other means, you know. I think a lot of it gets filtered out, but there's been some controversy about how much chemicals do make it through our water purification system, and are there a lot of estrogenic molecules in the water? No, I'm not wearing a tinfoil hat. I don't think the government is out to turn us all into females, like one patient actually said. Yeah, I thought it was pretty funny. So I was like, well, maybe you just have like a really disowned inner feminine. So we talked about that. That was an interesting conversation.
Can I ask a question about that?
Yes.
Not about the guy in the tinfoil hat, but
yes.
Isn't the menopausal empty heat symptoms that women go through, isn't that because estrogen is being reduced and there's not enough?
Yeah, I'm talking about it like in men though. Yeah.
Right, but how would that cause those? Like, do you know the mechanics of that?
It's pretty involved, and I'm not an expert at it. But I think that men's testosterone levels are decreasing.
Okay.
So I think the balance is different.
Okay.
The thing that you talked about is the water. Actually, I studied environmental science when I was working on my biochemistry degree.
Okay.
And I actually studied with Dr. Pepin, who was one of the leading experts on water and other things. And that actually is an issue because they say that they cannot remove the birth control pills that women take and the estrogen that they take from the water. And so during that filtration process, it does follow through. My hometown actually recycles water from black water and then returns it back to the stream. And they found that all the fish in the stream had turned female because of it. So there are things to that. It's not as crazy as you think.
Well, if I suddenly lose the ability to like grow my beard, then I'll know I have to stop drinking tap water.
Yeah. Well, they say it's a lot of things. It's just that's the source of our new shift.
Right. Okay. Well, that's one more thing to be anxious about. All right. Yes, there was a Simpsons episode about that with Blinky, the three-eyed fish. Remember that?
Yeah, that's
Yeah.
Yeah. And they made Mr. Burns eat the fish, but he couldn't, and he spit it out, and he lost the election. All right. So anyway, you can look at the channel problems. I've reviewed, obviously. I like to put this in just about every class note, so you have it there. The sinew meridian tests. Also just a little bit about, manual muscle tests, particularly the quadratus lumborum, the glute max, the glute med and min, the psoas, the internal and external obliques. I know it's not pronounced psoas. I just like to say that. And as well as the piriformis, which is not on there. I don't know why. But that also figures a lot in hip pain. So trigger points, you can treat trigger points, Osher points. I've given you a list. God, it took me like an hour and a half to put this together. I've given you a list of some extra points that support the back in general. These are the master tongue points that I use the most frequently. We'll touch upon those briefly in the context of each of the treatments. And I've also listed some other empirical points. At some point, the coordination between your page number and my page number breaks down, but I've listed these on page 3 and 4 under Master Dong and extra points. There's Master Dong points and empirical points. I have to say, if you really want to go all out, you don't need the 6th edition. You don't need the 6th edition, but I would get one of these at some point. If you're not gonna be interested in treating people with back pain, if you're maybe gonna have some kind of different specialty like pediatrics or oncology or women's health, well, even then I would say you could still get it. This is a really good book. Now, the 6th edition has some extra stuff like on like hand analysis and stuff like that. You don't really need that. Editions 1 through 5 are perfectly good. Okay? And why I like this is because it's the only text so far that goes into detail about why these points are effective, how they work in terms of affecting the tissues, how they work in terms of the substances, how they work in terms of the Zangfu organs, and how they work particularly with the channels and the different muscle systems. So it's really, it goes into like a fair amount of detail about like why choose this point rather than that point, because if you get like some books on Master Dong, it's just like back pain, list of these points, but you don't really know why. There's really not an understanding why. And unless you, and you're probably going to learn enough by the time you graduate, you will, and you already have a lot now, understanding of like the channel relationships, the Zangfu relationships, the meridian clock relationships. And there's also relationships along the Fuxi Bagua, which are illustrated in that meridian chart. Remember when we talked about the channel balancing a la Dr. Tan, right? Remember that meridian chart where there's like, the damaged meridian or the needy meridian on the column on the left? And then you've got like systems 1 through 5 or 6, right? They have different relationships, right? Interior, exterior, like system 3. That's like bladder balances kidney and kidney balances bladder, right? That's the interior, exterior, intra-elemental balance. There's also name sharing, right? Hand Taiyang balances foot Taiyang and vice versa, right? Small intestine, bladder, bladder, small intestine. So so when you look at some of where these points are, you start to see how they utilize channel balancing relationships as well as image balancing relationships. Hand equals foot, knee equals elbow, and so forth, right? But then they go into even greater depth of imaging, right? Where you can image like the entire torso on the head. So you understand why these points here will affect the low back, because this would be like, you know, the center, this would be like the navel, and this would be like, you know, the sacroiliac joint, right? And then this would be like up here would be like the neck, you know, or it can be flipped, right? So there's a lot more detailed imaging formats that break down those holographs even in greater minutia, right? So it helps to understand like why these Master Dung points do what they do, which then helps you decide which ones you want to choose based on where they are in terms of the image and based on what channels they're close to, and therefore how they might affect other channels, which is where the pain goes through, right? So does this make sense? Maybe a little bit, right? So
Take time.
basically, one second. Basically, it helps you understand the image relationships, like how one part of the body relates to the other part of the body that's in pain, as well as make sense of the channel relationships. Yes, John.
The numbering system for the master tongue points, you gave us a link earlier in the trimester, right?
Maybe. So the 11s, the 11s are the fingers. The 22s are the hand. The 33s
Okay.
are the forearm. The 4/4s are the upper arm. 5/5s are the sole of the foot. 6/6 is the foot. 7/7 is the shin and calf. 8/8s, the 88s are the thighs. 99 are the ears, and 10/10 is the head and face. And then you've got DT, which is the dorsal trunk, which is your back, and VT is the ventral trunk, which is the front of the torso.
Okay.
Right? So 11s, right? Points on the fingers. 22s, points on the hands, right? Sorry, I'm going backwards, right? 2/2 is the hand. 3/3 is the elbow to the wrist. 4/4 is the upper arm. 5/5 is the sole of the foot. 6/6 is the foot itself, the top of the foot, really. 7/7 is the shin and calf, the lower leg. 88 is the thighs. 99 is the ears. 10/10 is the face and head. DT is dorsal trunk, which is your back. And VT is ventral trunk, which is your front. Okay? All right. So we'll talk a little bit about these Master Dung points. The way I use them is in two ways. This is not in your notes, so you may want to write this down. The way I use the Master Dung points is I always want to attend spirit level blocks. And Bob Duggan used to say, never put in a needle until you've delivered a treatment. Which meant to say, like, use your words to deliver some kind of treatment, or your touch. Use your words, your touch, your presence to deliver some kind of treatment, which is then reinforced by your needles. So in a way, that's almost diagnostic. Like, what do you feel called to say to this person? What do you feel called to offer this person in terms of a state of being? Reassurance, deep listening, deep acceptance, patience, right? People hold in a lot of stuff, There's a lot of shame around desires, sexuality, past events, the way they've behaved in the past, the way they're behaving now, their thoughts, predilections. This is all shadow stuff, and this is like, this is what, if left untended, creates a lot of stagnant liver qi. And the diaphragm and the rectus abdominis, and particularly and the muscle strength of the core is really vital for a healthy low back. So deliver a treatment and then notice, oh, wow, this is what I feel really drawn to deliver. And that kind of, in a way, when I translate that into Chinese medicine language, right? Like I want to, oh, that they feel really called to give them a lot of reassurance. So what is that? That's like, you know, being able to kind of like accept, like, you know, like it's going to be okay. Like the future is uncertain, but it's possible to get through this. What do they need to get through this? Maybe they need patience. Maybe they need strength. Maybe they need a plan. Maybe they need, you know, connection, whatever. Like it goes off from there to the other elemental correspondences. And that helps to kind of create the backbone of my treatment plan. And then the channel system is what helps carry that out. Right? So, you know, maybe I'm doing, if I want to give them a lot of reassurance, well, what would reassure them? And I ask them, we talk about what would reassure you? And maybe they don't even know. Maybe they've never even felt reassurance. They don't even know how to envision it. So everything is like just dark and unclear. So they need some kind of whatever, like clarity, whatever, right? So that's going to guide you to certain points, maybe even to certain areas of the body, given what those areas do. Maybe it's about managing the situation. So maybe I do hand and wrist points, right? Maybe it's about being steady in themselves. So maybe I do more like core work, or maybe it's about connecting to some quality of their inner strength. So maybe it's an upper kidney point, or, you know, maybe their shen is a little bit rattled and they're finding themselves like going into like hostility and anger. So maybe I do, you know, the outer bladder line point for the kidney combined with the outer bladder line point for the liver or the gallbladder, right? To connect those two shen together, right? To anchor that. You follow me? Right? So then I'm looking at master dunk points generally in terms of what channels do these points engage and what's their relationship to my treatment principle, right? So, you know, maybe it's more about the chi, you know, being freed up and moving because there's a lot of stagnation based on deficiency. So I need to build and move. Maybe it's about like there's a lot of blood stasis in a certain area of the body. You know, maybe it's about, you know, how they're facing the world, and maybe I'll do points on the face, right? You know, I mean, all kinds of like little intuitive little hits. Like I would just let yourself run with it and experiment with it. Or, you know, what channel relationship is there to the channel that I'm treating, you know, in the low back? Like if I'm dealing with the kidney and the bladder, like what helps with the kidneys and the bladder? Well, you know, the meridian, you've got that meridian chart. And this is what Dr. Tan based his work on, like all these meridian relationships that Master Dung relies on. So, for example, if there's a lot, like based on the pulse and tongue, especially the pulse and other signs and symptoms, there's a lot of lung qi deficiency, but also there's like some stagnation in the lungs, right? Some coughing, some wheezing, maybe some heaviness in the chest. Maybe they experience anxiety, right? Maybe I need to do some work with the lungs and the bladder kidney. So maybe I'll bleed lung 5, you know, or maybe I'll do points for the waist, like on the lung, like around lung 5 area, right? Large intestine 11, right? Which balances the bladder and kidney respectively. Does this make sense? I'm not saying like, oh yeah, like I got this and I know how to treat. I'm just saying conceptually, are you following me? Right? So that's how yes, E-Lotus. So, you know, this is a nice way of using those points in terms of channel balancing and in terms of like dealing with certain substances, okay? So a nice way of looking at the Master Dunk points is looking at what are the channels they relate to, and, you know, activating that channel, like does that show up in terms of the correspondences of the patient, right? So, yeah. All right. So there's a bunch of empirical points. I do find myself doing like a lot of cupping and quite a bit of bleeding in low back cases, especially where there's a lot of stagnation. My sense is that, if you think about how liquids, like if you ever like had if you're pouring like something out of a cup, like out of like a mug or a teacup, right? Do you pour it really slowly or do you pour it quickly?
Quickly.
Yes. Why is that?
Otherwise, it'll drip everywhere.
Why does it drip?
Because you've explained this before. The molecules hold on to
Oh, I
each
talked
other.
about this.
Yeah,
Oh, okay. Yeah. So there's this viscous adhesion. So I think that when we bleed, it kind of like pulls the blood and fluids along. Sorry, I didn't realize. And this is the glory of having a poor memory, is that everything is so new.
It's okay. Repetition is good.
Exactly.
Love it.
I do a lot of cupping. In the cooler months, I do a lot of moxa and a lot of bleeding. Bleeding is so valuable. Oh my God, it's just so amazing. The points that I bleed the most are bladder 40, or Worsley's bladder 54, behind the knee in the middle of the popliteal crease or popliteal crease. I learned it as equilibrium middle. I don't know what you guys know it as. Something boring. All the TCM names are so dull. Or lung 5. Really nice point to bleed. All right. So most patients that I see fall into like 2 groups, and then we'll take a break. As I've mentioned in my notes, it might be page 4 for you, just under empirical points. So basically, people under 40 and people over 40. Most of the people under 40 are either athletes themselves, or they're very athletically minded, or they're very physically active people. They go to the gym, they work out, they like to bicycle or hike or climb. Maybe they do CrossFit. I love CrossFit, just love CrossFit. As I've joked before, it's how I bought my Prius in cash. Yeah, I tell you, when I started treating CrossFitters, it was like, whoo, yeah. Yeah. So then there's also the people who are over 40 who've taken total crap care of themselves, and basically have just like worn themselves down and are very deficient. And they've got like a lot, they're carrying like a lot of body weight in the front. Now, I knew a guy when I was living in New York. He lived like across the building from me, and he was a masoner. He was a mason and bricklayer. He was basically a bricklayer. And this dude, I mean, he could work. He was about 5'6". He weighed about 280, and I would say about 180 was like in his belly. I mean, this dude like had one of me like wrapped around his waist. Hugely fat. I mean, this guy was so fat. And he walked around like, I mean, he couldn't even put his arms down, like, and his like thighs rubbed together. This guy was like so heavy. I mean, this guy was like in shape, but he never got injured, never felt sore. Like, he knew the mechanics of how to do what he did. He was incredibly strong. He could carry like 2 of those big cement blocks. Like, he would just carry like one in his hand, and then he'd put like another one on his arm, and he'd like walk around. Like, the guy was just like so strong, but his mechanics were so good, and he was so physically strong. Like, his back was so strong, he could accommodate it. So I'm not saying that necessarily just because somebody has a big front that they're going to have a painful back, but it is, this is yin yang theory, right? So most of what I do actually is like working on the oblique muscles and the rectus abdominis muscles, as well as the psoas. So that's what I'm working on a lot, and trying to help people lose weight. And it's hard, especially in the winter, because we've got, How long have human beings been around? 2.5 million years. So we've got 2.5 million years of momentum to store in the winter. So we're not going to overcome that just because we're like juicing now. You know what I mean? It's like, which is actually the opposite of what you want to do. Like having this cold, like super concentrated meal in the morning. Yeah. So I have people make their smoothies with hot green tea and actually like, you know, limit the amount of like cold things. So, you know, these people are almost always extremely overweight. They have a history of poor diet, little to no exercise for the past 20 years. They're often suffering from multiple, you know, chronic conditions, and they're also on multiple medications. So, you know, all I have to say is don't work harder than your patients. All right. So you have to really work with people's mindset a lot when you're dealing with people's back pain, because they want to be able to, like, they want you to fix them right away so they can go back to abusing themselves and in a state of ignorance. And that's not my dance. You know, that's not what I'm about. So, so why don't we take a break until 10 and then we'll go through the rest. All right, so I just want to mention on page 5, there's important red flags to rule out. Basically, anything that does not subside after a physical trauma, they have to go to the ER. They have to see their doctor. I would send them to the ER. They may have internal injuries. They may have broken bones that they're not aware of. And this has actually happened, you know. One guy came to see me. He was actually the father of another practitioner who came to see me. And I was just like, you know, he only got like maybe 2 or 3 hours of relief. And then it was like, it came back full bore. And, you know, I was seeing him, like, I saw him a couple times. I was like, you know, there's something seriously wrong here. And he had some broken vertebrae. He had some cracked vertebrae and some internal injuries. So, that, you know, that was a really serious thing. Anytime there's any kind of like numbness or paresthesia with concurrent inability to urinate or defecate is an immediate 911 call. All right. This is extremely serious. There's something called cauda equina or cauda equina. And if it's not treated right away, and it will need surgery, the person could be left with permanent damage. Very serious. So any injury, anything that ever really interferes with one's ability to urinate, defecate, or swallow, not really in this case in terms of back, but anything along those lines is an immediate 911 call.
Can
Okay.
you type that condition into the chat, please?
Yes, it's in your note though. It should be on page 5. It's called cauda equina.
Could we further say either the inability to urinate or the inability to control with numbness?
Yes.
So it's one extreme or the other?
Yes.
Okay.
Yes. And yes, if person's like urinating without control, I mean, one, that's might be a sign of MS, but there could be like severe damage to the spinal cord, especially in the lower part of the spinal cord. Upper part, you're going to get like inability to move your arms and legs. You know, you're going to get like motor impairment, which of course, obviously, is a big red flag as well. So, also anything that's concordant with weight loss, sudden weight loss, inability to sleep, severe night sweats that are sudden. Okay, that needs to get looked at. There could be a severe infection. It could be cancer. All right, so just, you know, make sure you look at that. I'm gonna share my screen. We're gonna look at this PowerPoint very briefly. There's a couple PowerPoints I want to do. All right. Very briefly. So just evolution of back pain. Let me just move this, sorry. There we go. So, basically what you're looking at is some kind of sudden impact injury. There's going to be some tissue damage. It's going to affect the way they stand. It's going to affect the way they move. They're going to have pain, and it's going to impair their ability to do certain things: grip, walk, stand for periods of time, sit, drive, so on. Or some kind of sports injury, right? So there's some kind of sudden impact trauma. They've fallen. They've got no car accident, bicycle accident. Something that's pretty obvious, right? That's not going to be outside of it's not going to be something you're going to miss. Sports injury, generally it's some kind of like minor tissue damage. Maybe they pulled a muscle, sprained a muscle, strained a muscle, more likely strained. Sometimes they will have sprained it or pulled something. It will affect their posture. It will have pain. And it will impair some function, although it might be like a higher level function. So it might not be something as simple as like standing for a period of time or gripping something or being able to sit comfortably. It might be like, these dance companies that I treat, might be their inability to, perform some kind of dance maneuver in that regard, which is not something that, we put our bodies through. So that's generally what you're going to see on an acute level. And this is where the sinew meridians come into play very commonly with either kind of sudden trauma or a sports injury. Your sinew meridians, the primary meridian evaluations, doing the tonification and or sedation points, the shoestring point combination is very helpful to kind of get things moving once again. Chronic problems are you're going to have to build as well as move, right? Because there's a deficiency from something's deteriorating. It's not getting fed the chi and the blood it needs to maintain its integrity, its physical integrity. So the spine deteriorates. We know this is spondylosis, and there's several stages of spondylosis in increasing with increasing difficulty in pronunciation. Spondylosis, spondylolysis, spondylolisthesis. So this is going to be generally some kind of soft tissue problem involving the muscle. You'll see what Matt Callison calls chi edema, like you'll palpate the paraspinal muscles, you'll palpate the muscles along the back, maybe up around the neck, and it'll feel like you're pushing into something squishy. Right? He calls that chi edema, where there's like chi stagnation, but not so much blood stagnation yet that's created like pressure and pain with palpation, right? It's just basically they're not just getting enough chi, right? The chi is getting choked off. Often what happens over time is that there's weakened spine and spinal muscles that are aggravated by some kind of activity, depending on the person's lifestyle. It might be some kind of athletic endeavor or some sports that they play. It's going to result in some kind of muscle imbalance, which you'll do muscle tests and they'll show up as weak or stimulating pain. There'll be a structural imbalance, like we'll get into this, like maybe like the hips are tilted or one shoulder is higher than the other, or the forward head. We talked about upper cross syndrome. And it's more often than not in your non-athletes, this is going to be some kind of repetitive stress issue. And prolonged sitting is repetitive stress, which I am kind of experiencing now. All right. So the basic evolution for most people, especially over 40, there's going to be some kind of degenerative change in the spine through age and age plus hard work, or age plus long time sitting in a chair working in a computer, or age plus poor posture, poor mechanics plus emotional stress, psychological stress. All of those are going to inhibit the flow of chi and blood through the body. The tissues are not going to get what they need to maintain their integrity and function. Things are going to break down, and this is going to collapse the space that the spinal cord or the spinal nerve roots coming out of the trunk of the spinal cord. It's going to deprive them of the space they need to function. So there may be some kind of deterioration in in the space for the spine itself, the spinal cord foramen, or there may be some damage to the ligaments that sort of sheath the spinal cord, right? Which then create pressure at some point along the spinal cord, which then is going to affect the nerve roots, which then is going to affect the way the muscles and other tissues are innervated by those nerves. So you get weakness, atrophy, pain, not in that order, usually weakness, pain, and then atrophy. Or there may be some kind of issue with the disc, right? The disc is starting to dry out and get thinner. That's going to decrease the space between the vertebrae, which can then put pressure on that nerve root that's emanating from the spinal cord. And again, decrease innervation to the deep paraspinal muscles and the other muscle groups known as myotomes in the extremities are going to suffer from poor circulation. So there might be pain, weakness, and eventually atrophy, numbness, paresthesia, right? This radiating numb feeling, or radiating pain, radiculopathy, right? The former is paresthesia. So you might get some kind of like radiating numbness without pain, that's paresthesia, or radiating pain with or without numbness, that's radiculopathy, okay? So basically, you know, the river is not able to irrigate the small streams that run through the terrain of our muscles and tissue. And that's going to inhibit the qi and blood that move through the channels. So that's why a lot of what you're going to treat is the Huatou Jiaji points, which are at the facet joints, which also, if you kind of look at that second area under nerve root irritation, not just decrease innervation of the deep paraspinal muscles, but you're also going to get a loss of function and more stress on the facet joints, right? Because if the disc space thins, there's more pressure on the facet joints, which, you know, where one vertebrae rests on top of another. And so that can create irritation and inflammation and then therefore pain, and then we're off to the races. Right, so the Huatou Jiaji points are really good for treating the paraspinal muscles and the facet joints. So here we have the evolution of back pain, right? You know, as time goes on, our posture suffers, right? And so what happens is you could have a bulging disc. So at the top, so to your right is posterior, to your left is anterior, right? So in that space, so if you see like the disc and then you see like a white space, that's actually where the spinal cord would be going. So that bulging disc would be moving into that space that's occupied by the spinal cord. So it's pressing up against the spinal cord, actually really against the dura mater, the thick fibrous ligament that protects the spinal cord, right? It's like a sheath around the spinal cord. So that bulging disc, it hasn't blown out, right? It's like, you know, the balloon is still intact, but it's putting pressure on the spinal cord or the dura mater, and that puts pressure on the spinal nerves that come out, and that would be like coming out towards you from your computer screen and out away from you, sort of going into the screen, right? So they come out laterally, which is to your view, towards you and away from you. So here you see the herniated disc, the next one down. Imagine how much pressure that's pushing against the dura mater or the spinal nerves. And then the thinning disc, as you can see, it compresses the space, so there's less space in those foramen, right? And then that puts pressure on the spinal nerve roots as well. Of course, with disc degeneration and osteophytes. Osteophytes are sort of like these, like almost like bone spurs of the vertebrae. So the bones are not smooth, and you know, it's not just sitting in this like vacuum of empty space. There's a lot of other tissue that surround the vertebrae, and you know, they're going to be like, it's imagine like walking around with like a little small stone in your shoe, or you've got like at your waistline, if you're wearing a belt, imagine you know, there's like a pin, like, you know, like a safety pin that's been opened, you know, from the dry cleaners, and that's like sticking you in your waist. So similar, this is what people would experience. Just something I brought up from this book about spinal disorders, fundamentals of diagnosis and treatment. Even slight irritation of the spinal nerve that impedes the flow of neural impulses for a period of time can rob the innervated tissue of its nourishment and cause signs and symptoms as dysfunction. That's qi and blood deficiency. All right. So I've given you some images that show you the the nature of the structure and some of the terms that are used. So this helps you when you're doing your own investigation, your own reading. It's important to know the lingo so you understand what people are talking about. So here you see, like, moving from spondylosis to spondylolisthesis, there's some kind of degeneration going on, the pars interarticularis, right? So that's that space where these vertebrae are shaped in a way to help us deal with gravity and to help us deal with the strains and stresses that the back is under, because obviously we want to protect the spinal cord. That's, you know, next to the brain. I mean, that's one of them, and probably maybe even just as important to protect and to keep strong. So this adds structure and resiliency to our ability to move. So you're seeing a wearing down of this interarticularis structure, and then eventually it may actually break in the vertebrae, and then everything shifts forward. And also, as you can see, I mean, that's sort of where the spine kind of runs through. So there's an enormous amount of pressure on the spine. It can be so severe that it can actually render people paralyzed. So, you know, obviously we carry a lot of physical baggage as well as emotional baggage, and that tends to wear down on the low back. Kids these days, I don't know, like if you're watching kids like walk through the neighborhood, they've been giving like enormous amounts of homework and they're walking around like Sherpas. It just seems absurd to me, but that's the way it is. So, you know, you have to teach kids the proper mechanics so we can kind of prevent injuries over time. There's a picture of me playing baseball as a child. No, not really, but I often look like that. And so, you know, injuries that, like, for most of us are the age where, you know, you get some kind of injury, they tell you to just kind of like walk it off, rub dirt on it, you know, just basically just kind of like blow it off. Nowadays, they really need to be followed up with a lot of care and management and treatment, right? And here you can see like another example of a traumatic sports injury. Yeah, I mean, these guys, it's like, it's no joke, man. Look at where this guy's about to land. Whew, right on his tailbone.
Right.
Not good. Not good. Okay, so, all right. So that's that. I want to go over another, if there's no other questions, I want to go over another PowerPoint with you all on postural assessment. Any questions about the anatomy? Okay, so one of the things that I really got out of the course with Matt Callison, and this is available in other places, not just through him. I mean, I discovered it is actually really a common thing. It's me, it was like this new exotic thing to like, oh, you know, like, oh, I can do this, and this really helps my patients. It's basically called a postural assessment. And so what we're doing in the context of the low back and tomorrow and the next week, the hip, is we're looking at how the body is stacking up in terms of its anatomy. So the things that you're going to be looking for, and this is on page 5 of your notes, we're going to be looking for the whether there's an elevated ilium, and an ilium is the fancy term for your hip bones, right? That's the butterfly of your hip. And then whether there's some kind of posterior or anterior pelvic tilt, or if there's some kind of pelvic rotation. So I'm going to go through this a little bit here, but basically in your notes is giving you some understanding of that. So we are forward walking creatures. So our hips are a little bit bent or tilted forward to help us propel forwards, right? We don't walk backwards. That's why our knee bends anteriorly. Our hips are shifted anteriorly, right? We are meant to walk forwards, which I think is also, and laterally. And we can walk backwards, but generally we have to do it slowly. And I think these are all psycho-emotional signs and clues as to how to live. Like lateral maneuvering is okay, but not sustained. We need to keep moving forward. We're not meant to sit still for a long period of time. It's good to walk back occasionally, but to do so thoughtfully and slowly. All right. So all kinds of life lessons in there. So basically what you're doing is we're going to be assessing the, whoops, wrong one. We're going to be assessing the low back. Let's see. Yep. Okay. Wrong one here. Let me get the other one. Okay. Pelvic tilts. All right. Okay. Can you all see this? Pelvic dysfunctions? Okay, great. All right, so what we're looking at is anterior pelvic tilts, posterior pelvic tilts, lateral tilts, which is also termed elevated ilium. We're looking at rotation and the SI joint. All right, so I'm sorry this is a little bit fuzzy, but this shows you a normal tilt in the center is about 10 degrees, about 1/2 an inch, maybe a 3/4 of an inch on a bigger person, where the posterior superior iliac spine is a little bit higher by about 1/2 to 3/4 inch than the anterior superior iliac spine. Okay? In the Canvas site, under the modules, I've given you loads of images that are labeled that you can look at to refer to and gain some greater understanding of the anatomy. When I started taking Matt Callison's course, I had very limited understanding of anatomy. I couldn't even remember what an ilium was. So it was very challenging to kind of learn this new material while learning basic anatomy. But it can be done. So like, don't stress. It comes with the doing and with the application. You'll get it. Don't sweat it. So there can be an anterior pelvic tilt where, you know, we'll go over like how to find the PSIS, how to find the ASIS, and, you know, are they anteriorly tilted or posteriorly tilted? And I would like to make an exception, and this may not be in your notes. If the ASIS and the PSIS are exactly level, that is a posterior tilt. If the ASIS and PSIS are exactly level, that's technically a posterior tilt. Because a normal pelvis should be slightly tilted towards the anterior. So these tilts can be unilateral, just on one side, or they can be bilateral. The bilateral tilts, they might be relatively equally tilted, but one might be tilted more than another. So in a unilateral pelvic tilt, or in a bilateral pelvic tilt where one side is tilted more than the other, will result in what's called a pelvic rotation, right? And that makes sense. So watch, let me see here. So can you see my hands? So here's your right pelvis, your left pelvis. If they're both tilted, it's even, right? If one is tilted and the other is not, it's gonna torque the muscles and it's gonna rotate the pelvis, right? If one is posteriorly tilted, right? Again, these aren't independently moving. I mean, they can move a little bit independently, but there's a lot of ligaments and a lot of muscles holding these together. So if I'm posteriorly tilting one, I'm going to torque it this way. So there may be a pelvic rotation, right? If it's tilted this way, it's right. I mean, imagine like taking your hands on your hips and moving one way and the other another way. That's going to torque those ligaments and muscles to twist the pelvis. And that's going to affect the diami. And the daimai is what holds all of the other and sort of maintains the integrity of all the longitudinal meridians. So this is going to have a real effect on people. So when we talk about rotation, imagine there's a flashlight coming out of your belly button, right? So if I have a unilateral anterior pelvic tilt on the right, that's going to be moving my hip this way, and that's going to turn the flashlight to the left. So here's my hips, anterior pelvic tilt just on the right, torquing things like that. I've got a flashlight coming out of my belly button that's now pointing to the left.
Time.
Yes, sir.
Would it be to the left and slightly down?
Not always.
Okay,
Not
because
always.
I'm thinking of the rest of the body, the leg, and if that motion is happening, wouldn't that also tend to indicate that there's going to be a knee bent?
More often than not, yes, and this will affect downstream.
Okay.
So more often than not, it will be pointing it to the left and then down a little bit, yes. But it depends on some other factors and how people cope. So that is often the case, but not always the case. But that's a good point. Thank you for bringing that up. That's very clever. All right. So yes.
I'm wondering, is this these kinds of injuries, is this a time when you work in partnership with a chiropractor or somebody, physical therapist, because they've got to stabilize that joint, that pelvis, or it just becomes a block to treatment?
Right. Well, this is why we will cover restorative exercises towards the end of the course. So there's things that actually you can do to shift that structure to basically reestablish normal pelvic arrangement.
And then in partners, so it's really a partnership with the patient, because you can, like, even if they were going with the chiropractor, if they need to be doing something in between, or they're just gonna habitually fall back into the misalignment.
Like, just to jump ahead very briefly, like I tell them, like, okay, we fixed this, it's not gonna hold, because you're gonna go back doing your own thing. We have to do these exercises for the treatments to hold, or the PT exercises, or the whatever. You can have all the chiropractic and acupuncture in the world, but if you're not doing the exercises, it's not going to hold. Yeah. It can hold some, hold some, but it won't maintain, you know what I mean? Like you have to work it. Yeah. Yes. Thank you. That's a great point. All right. So let's get back to the PowerPoint here. Okay, so that's what a pelvic tilt looks like. Again, if the ASIS and PSIS are exactly level, that is technically a posterior pelvic tilt. All right, so there's ways which we'll go over about how to find the PSIS and the ASIS. Basically, if you want to find the ASIS, find the middle of your thigh, and then just keep coming up. Just go north, and eventually you'll get to your pelvis, and you'll be in sort of like right in the area where you feel these two bony prominences. Some of us may be bonier than others, but if you push with the heel of your hand, you'll feel it. And then with the PSIS, if you kind of come up from the top of the butt crack, right, the sacrococcygeal hiatus, right, if you come at the top of sort of like the gluteal cleft, as they say in polite company, and then draw sort of like a triangle, like almost 45 degrees, maybe 35 degrees up and outwards, you'll come to the PSIS. Excuse me. It should not be higher. Now, this drawing, like this image, I think it's a little bit off. I think the PSIS is actually a little bit higher than the top of the sacrum, in my experience. All right, so here you can see the kind of like the mechanics of this. You don't have to memorize this, but just realize you're in a closed system where you have some muscles pulling up and some muscles pulling down, right? in terms of the way they contract. Okay, right? And so you've got this dynamic homeostatic tension that allows us to walk and move and do everything, right? So imagine like this wheel, and sort of like the greater, right at the center of the greater trochanter is the center of the hub of this wheel. So you've got forces pulling up anteriorly and posteriorly, and you've got forces pulling down anteriorly and posteriorly. So on the left, you see with the anterior pelvic tilt, the rectus femoris is maybe in a shortened, overactive position. So it's pulling down. And if the erector spinae are weak and can't be the yin to that yang, and if the, right, then that will allow the ilium to be pulled, the hip to be pulled down. Similarly, in a posterior pelvic tilt, if the hamstrings are really tight, if the glute max is in a overactive, shortened state, and the rectus abdominal muscles are weak, right? Then you have the opposite problem. You have more of a posterior pelvic tilt, right? Things are being pulled down the back line, and the front can't hold the front of that hip in place. Okay, so here you see like an anterior pelvic tilt to the right, right? So basically, again, the rec fem is overly shortened and tight. The erector spinae, very tight. The iliopsoas is weak, okay? Which all conspire to pull the front of that gentleman's hips down, right? And it also, see what it does to his low back? The increased what's called lordosis. That's the curvature, that concavity of the low back. And that puts an incredible amount of pressure on the posterior aspects of the vertebral column, right? So, the space between the posterior part of the vertebrae is crunched closer together, which puts more pressure on the discs, which then increases the likelihood of a bulging disc or even a ruptured disc. All right, does this make sense? Anybody not like get the concept of this, right? It's a lever, right? You've got things pulling down the front and things pulling up the back, and then those are counteracted by things pulling down or held and rooted, right? And it's like this system, right, that allows us to move this way to keep things in check. You also have the obliques that keep things like, and the TFL, the tensor fasciae lata, and other muscles to keep things like this way, right, side to side, right? I didn't see, hold on one second, let's see. Oh wait, was there more to it? I think there was, hold on a second. Oh yes, there was more. Okay, I thought I was at the end. I was like, wait a minute, that doesn't seem right. Okay, hold on one second here. Okay. Okay, so just as we had the upper cross syndrome, this is the lower cross syndrome. We don't really talk much in the literature about lower cross syndrome. You won't often see that. But like in the case of a bilateral anterior pelvic tilt, where the PSIS is higher and the ASIS is lower. So you've got the erector spinae, right? They're tight. The abdominal muscles are weak. The iliopsoas is tight. So you've got things in the back pulling up and in the front pulling down. And the antagonists that keep those muscles in check, which would be the abdominal rectus abdominal muscles in the front and the gluteus max and the hamstrings in the back, are weak. So they're not able to hold things in place. So things are being pulled up in the back and down in the front. Okay, posterior pelvic tilt, it's the exact opposite, right? The rec abdominis are tight. The hamstring and glute max is tight. So things are being pulled up in the front, down in the back. The erector spinae are weak, right? The muscles in the front are weak in the lower part, okay? So, but sometimes there can be what's called a unilateral pelvic tilt, right? So this could be anterior or posterior. And the tilt could be greater on one side than another, right? So with, and we'll get into the treatment later, but basically when you're dealing with either a unilateral pelvic tilt or the side that's like more tilted than the other, you begin by treating the greatest imbalance, right? All right. Okay. So with the unilateral pelvic tilt, you'll often see an elevated ilium, that is an ilium that's, or a hip that's higher on one to the left or to the right. You'll most likely see a rotated pelvis. And we'll get into the etiology and treatment of all that in a bit. Okay. All right. So here, this is an elevated ilium or a lateral pelvic tilt, right? So similar to how the relationship between yin and yang is, right? One could be more exuberant than the other. You know, there could be an excess of one or the other, or there could be a deficiency in one or the other. So the others that's like, you know, like normal levels would be considered like in repletion, but that's not like the case. So you could have one side dropping more than the other, and you could have one side more elevated than the other. The good news is you don't have to worry about which is which, because the treatment is the same. So don't worry so much if like one pelvis is dropping or the other side is hiking up higher. They're treated the same way. Okay. But just know one could be higher or what could be dropping and the other side could be normal. All right. So basically these muscles are going to be like the ipsilateral abductors and the contralateral adductors. Don't worry about this. Like we'll get to this later. I just wanted to put it out there so you'd have it in case you want to refer to it later. This is going to figure later on when we talk about how to correct these using motor points for particular and specific muscles. But this gives you like the details of which muscles are basically out of balance. Okay. All right. So with all pelvic tilts, it's going to affect the back muscles, particularly the erector spinae, to some degree, the lats. That's what gives that sort of like V shape to the back, the latissimus dorsi, as well as the QL and the iliocostalis. Okay. You don't have to worry about that for right now. Just know that also there can be a rotation in the pelvis. Okay. Which again, you know, that the flashlight is facing one way or the other. And it's usually in the direction away from the one that has the greatest tilt. Okay. So if the left side is forward, it's going to be rotated to the right. If the right side is forward, it's going to be rotated to the left. Don't worry. This may seem hard to follow right now, but I guarantee you, after you focus on this, like 2 or 3 patients, it'll make perfect sense. All right. Briefly, just about SI joint dysfunction. You know, you've got ascending and descending forces. Everything is yin yang. So we're looking at, you know, how well does the sacrum sit or rest into that sort of butterfly of the hip, the ilium. Okay. I've just given you some, you know, detailed information about the anatomy. There's a lot of ligaments holding things together, right? Here you can see more around the sacrum, right? And this is basically looking at how everything stacks up. All right, and I've just given you some images of some athletes. You know, this is how you can put some pressure on the SI joint, right? These seem like really normal, mundane activities, and they are, but these can put a lot of strain on the SI joint. Okay, all right. All right, so let's take a brief break. And in your abundant spare time, I want you to take a look. I think it's your page 6. I'm not sure, but it'll look like this. There's a picture on your notes here, and then there's a listing of, I've sort of shortened your learning curve, given you a break, and listed the muscles and some treatments that I do that are involved in the pelvic tilts. And just very briefly, before we take a break, I just wanted to go over some terminology. So you'll see the terms locked short and locked long. What this refers to are the state of the muscles in terms of their ability to contract and relax easily. If a muscle is locked short, it is overactive and shortened. That means it's like it's overly contracting. So when a muscle contracts, it shortens. And when a muscle shortens, it brings the two ends closer together. That puts pressure and tension on those tendons, which anchor the muscles to the bones, as well as to whatever joints are in proximity to that tendon. All right? So there's a lot of muscles that work around the back. Those muscles are anchored to certain bones by tendons. Those bones are connected to other bones by ligaments. So when you have these muscles in an overactive, shortened position, locked short, and they're locked that way because they don't have the proper communication with the central nervous system, right? They're in some kind of spasm or overexcited state, right? And think about what happens if you're overexcited, right? Eventually you can become anxious and kind of manic. That's an excessively yang state, right? And things can't relax. And if things can't relax, they can't move. So you get stiffness and pain. Locked long refers to something that's in an inhibited state. Inhibited. That means the muscle fibers can't fire. And if they can't fire, they can't contract. And if they can't contract, they can't activate that muscle. Now, both may feel tight when you palpate them. So that's why I'm not concerned about muscle tightness, because you can have muscle tightness in a locked short, overly active, shortened, overactive muscle. You can also have tight. A muscle can be tight when it's lengthened, locked long, and inhibited. It doesn't always feel that way. More often than not, the locked short muscle that is overly active and shortened is going to feel generally more tough. You're going to feel more muscle knots, right? It'll feel more resilient and less yielding to pressure. And that is in a state of repletion excess. And then more often than not, the locked long, inhibited, weakened muscles will feel overly resilient and will feel, overly yielding with pressure and will feel weak. But they can both feel tight, which is weird, I know. But just note, I just want you to know that. So when you palpate, when you're ever able to touch another human being again in person, like you won't be confused by that. So I've given you the muscles that are involved in the pelvic tilt. If it's locked short, it means it's overactive. If it's locked long, it's inhibited and underactive. Is that clear? Does that make sense? Okay. All right. So let's take a break until 11 and then we'll come back and we'll talk about the individual conditions and the tests. So we're this collection of virtues that are always, just like every seed eventually will try and sprout when the conditions are right, that you can't stop it. You cannot hold the bud on that tree tightly enough to keep it from blooming, right? I mean, this is the power of vitality itself. And it cannot be reasoned with. It cannot be rationalized. It cannot be repressed and suppressed, right? And I think people suffer because either they've never been given the opportunity in terms of the conditions, right? Like certain seeds need more heat and light. Certain seeds need more cool and damp, right? Some cacti, they're not going to grow here. Like I'd love to grow olive trees in my backyard, but the conditions just aren't right. So, some of us need to leave our original garden and go and find another garden with better conditions. You know what I mean? Like maybe the family you grew up in is wonderful and well-meaning as they are. Maybe they just didn't foster the conditions for you to manifest your virtues. And what will get our attention more than anything else is pain. It's an invitation to change. It deals a lot with the wood element. But what nourishes the wood, what nourishes change is like, is some kind of pain, some kind of dissatisfaction, some kind of deficiency, right? We have lost touch with or are being invited to connect to that unmanifested part of ourselves that maybe we're aware of and just haven't had the courage to bring it out, or we're unaware of it, and life is now forcing us into different conditions, into a different state of thinking, of believing, of posture, right? Maybe I need to stand up to the world more. Maybe I need to throw my shoulders back and walk taller and slower, right? Maybe I need to shift my weight into my hips more, which means I need to be more settled and grounded, which might show up as confidence or ease, right? You know, I think our posture is a metaphor for our mindset and our belief set. And so back pain, I think, often shows up when we are physically and psycho-emotionally and even on a spirit level not connecting to the zhongqi or the zenqi, right? So I may not be sitting right, I may be sitting too much. That's a physical level thing. But why am I sitting so much? You know, like, is that a metaphor for something? Am I too inert? Am I too, am I retreating from life, right? Do I need to get up and move around more? Which I then have to create, I have to change the conditions of my life to accommodate that. And I have to be sometimes unreasonable about that. That's why I say to students, you know, if you get antsy or whatever, you need to get up and move around, get up and move around, right? I don't care, right? So we live in a very structured environment which provides stability. That's the ligaments and the tendons, right? So we need structure, we need rules, we need guidance that provides stability. But at some point, like, do they diminish our flexibility, our possibilities for living? So you've learned a lot of shoulds and shouldn'ts, which are great. Don't leave the house without brushing your teeth. You know, don't leave the house without clothes on. Look both ways before crossing the street. You know, like, don't drive too fast. You know, use your turn signals. These are all, you know, wear a mask, right? And people are like, it's against the Constitution and you're inhibiting my freedom. Well, you know, stop acting like a 6-year-old, right? So I have strong opinions about this. So, but some rules, you know, need to necessarily, for each individual, they need to be bent a little bit. You know, the thou shalt and thou shalt nots may not necessarily fit you perfectly, and therefore you may need to change. And the people around you in your culture may not appreciate that. So you have to kind of retrain people. I'm sorry, my wife just sent me a text. I have to send her something really quick here. My apologies. Okay. So this shows up because people this is an opportunity for people to tap into their strengths, right? The kidneys are responsible for the creation of power. What gives us our power are hidden virtues, our inner virtues that don't show up necessarily like when you just look at somebody, right? You can't necessarily tell by their outer appearance what their virtues are. So you have to, this is something that it's like back pain can be an invitation to reconnect to our inner virtues, which are our inner strengths. And they may actually be manifesting in behaviors that are, you know, not harmonious for us. But again, if you can look past that and say, what's trying to arise here? right? If I'm drinking really heavily, what is it that my spirit is longing for? Maybe it's freedom, maybe it's ease, right? So how do I manifest more freedom and ease in my life? By taking a certain amount of control over my life, right? And that's what allows me to make decisions, right? Now we're moving into wood. I can make plans and decisions, which then help facilitate the manifestation of that. Anyway, I didn't mean to go off on such a long tangent, but I do believe that most of the people that I treat, you know, they're dealing with this. And when we do talk about this, it makes a huge, huge difference. It makes a huge difference. All right. Any questions about that before we go on?
Time, is this something that like,
Oh, wait, I'm sorry. I had my headphones on. Have you been able to hear anything I said? Because I realized I had my headphones on.
Yeah, we can hear you.
yes.
No problem.
Okay, because I had my headphones plugged in. I'm thinking, oh shoot, they probably didn't hear a word I just said.
We would have told you long before this.
Right.
Okay, thank you. Sorry, I was like, oh my gosh, I had the headphones in. All right. So any questions about that?
So apparently like Bob Duggan was infamous for the bomb dropping question, like identifying what the big elephant in the room was and not letting it just sit. So this is kind of an intuitive ground, sort of speak, in knowing your patient well enough to, can I just go in with the big question, or how do I do this dance? And I wonder, any advice into feeling your way through that, or you just got to feel your way through it and muck it up a couple of times? And
well, you know, my teacher, Dr. Ibrahim Jaffe, told me once when I first started, like, you know, following this particular spiritual path, he called me by my Sufi name, which is Noor, which means light. He's like, Noor, you know, for you, what I recommend is screwing up from your heart at least once a day. Right? That's what I would recommend. So look, you know, you have some sense about what elements they may resonate with more than other elements. So do your best to match them, energetically presence these particular elements, right? That you think maybe they're more fire than water. I'm not sure what they are, but I think they're more fire than water. So I'm going to embody fire. And then you speak from that place by matching their posture, voice tone, breathing. You know, I'm constantly checking myself. And if I can match them, where they're sitting in the chair, their way they're speaking, their breathing, their energy level, their volume, I embody a particular element as best I can. It's not my strength, but I do my best. And then based on the nature of the person, you're getting a sense of how big the doorway is for you to, you know, bring this forward. And, you know, I would say work with what feels natural to you in the moment, as natural as it can, because we're always sort of like half in our heads trying to kind of figure out as we do. But whatever feels most natural in the moment, go with that. You can always see how it lands. And I can assure you, Bob often didn't really care how it landed. Like, he was more than happy to trigger the living bejesus out of you. And he was quite fine with that. He was not about like making sure I was comfortable. I mean, he was constantly like provoking me. And he seemed to kind of almost enjoy triggering people to some degree, because I think, but then he would walk them through it. He wouldn't just like poke them and then leave them off to their trigger. He would like stay with them and work with this person. He was very deeply engaged and talk people through it. And so you can even say, I can see what I've just said triggered you. And I get that. So what I would like for you right now is like to just notice that you're in reaction, but also, you know, look at also what else is like behind what that's about. Let's look at your goal. Like, let's look at what it is that you want to achieve. You know what I'm saying? So I think just over time, you'll just assume more and more authority in the treatment room. Like I say things now and do things in a way I didn't used to, because like, I know I'm right. Like I can see it, I can recognize it. And so, and my patients get that I really care, and it's not about me, and it's not about their trigger. And I make space for their trigger. I make space for whatever shows up. People can be, do, say whatever they like in the treatment room without judgment from me. And they get it because they feel it. And so I would just say, like, keep letting your desire for service be the carrier wave that delivers everything that you do and say. And people are going to get upset. It doesn't happen often, but it does happen. But engage in the upset. Don't retreat from it. Like, oh, you seem upset. Has this triggered you? All right, let's, you know, like work with that. Like tend to them in the trigger. Okay.
Thank you.
Because I often say, look, you know, like I care too much for your well-being to waste your time and your money. Like let's deal with this. Because and then this is what I did not get from Bob, but this is from me. And I say this to my patients explicitly, because at the root of this is one of your great, beautiful virtues. That's why this is so hard to change. That's why this is so persistent. That's why this has been chronic. This is why it hasn't gone away, right? Because it may be manifesting in this really ugly flower, but underneath of this are some really beautiful roots. Your mind just hasn't figured out yet or learned how to manifest things in a way that beautify your life. It is always rooted in some beautiful, gorgeous, wonderful virtue. Always. It's natural law. We just have to uncover it and bring it forth. Exactly. You were in my mind. I was bringing forth the lotus coming from the mud. I think that's a beautiful example. And I think that that's absolutely true. I think it's natural law. And so when I focus on that, people hear things a little bit differently. All right. So, okay, enough of that. So let's go on. I just want to call your attention to some of the tests. I've given you written out instructions how to perform the tests. I've given you links to look online to see the test done. I've given you why we do the test, what we're testing for, what a positive test indicates. And I've organized them in like several basic categories. The first of which may be on the top of your page 7, are the nerve root compression tests. That means that for some reason, the nerve root coming out of the trunk of the spinal cord is being pushed on and compressed, which then activates it to fire, which then leads to either overcontraction of a muscle, or it inhibits the ability of the nerve to fire, which then leads to weakness and inhibition, which is locked short, overly active and shortened, locked long, weakened and inhibited. Okay? So I've given you the tests there. The ones that you're going to do are like the straight leg raise, the slump test, the heel toe walk, which is basically you have the patient take about 4 or 5 steps on their toes, tippy toes, and then have them take 4 or 5 steps on their heels. That may seem weird, but they can actually do it. And then the femoral provocation test, which is kind of an okay test. It's all right. And then the stork standing test, right, which can also be for nerve root compression or a facet joint dysfunction, right? So you may, with the standing stork test, this is going to give you a little bit of differentiation, because all these tests are really about differentiating, is it this or is it that? And basically what you're looking for, is it like a soft tissue muscle problem, right? Which is, may have some radiating pain, may have some radiating paresthesia, some numbness, but it shouldn't follow a line. It won't go probably anywhere further than below the gluteal fold, right? Which is Worsley's bladder 50. I don't remember what it is in TCM, maybe bladder 36, I can't remember. But basically it's like right at the bottom of the butt cheek. Soft tissue is also generally more achy, but might be punctuated by sharp pains in the local area, which make them kind of stiffen up, right? It will generally be worse with some kind of weather pattern. It will respond well to either heat or cold. And people will feel it, they'll press like on the muscle. There won't be like this radiculopathy, right? So that's, you're looking at mostly back strains and back sprains of the muscle. And those are almost always going to involve the quadratus lumborum. They're going to almost always involve the rectus abdominis. They're going to almost always involve maybe the glute med, glute min together, like these muscles on the quasi sides of the hip, or the glute max, right, which is the big butt muscle, right, which gives shape to the booty. Those are going to be the big ones involved, as well as the obliques, the internal and external obliques. And each one of these has a motor point, which I believe I've given you the locations for. And if I have not, remind me again, and I will. So the soft tissue injuries, involvements are generally going to be the ones that respond most to the sinew meridian tests and the primary meridian tests. So they're going to feel it in the muscles. If they feel it, this is like a little aside, and they mention this briefly in Legge, but they don't expand upon it. A lot of times people will get this pain. So here's the sacrum, right? Here's the sacrum. And then here's like the spinal cord, right? L5, L4, L3, and so on. And there's the paraspinal muscles, right? You've got your ilium. Oftentimes, right across the top of the SI joint where L5 and S1 meet, oftentimes people experience this pain kind of like in a band, either very narrow in height or short in height or high in height that goes across. It might even wrap around to the front, but more often than not, it's just like all the way across. I have found that you have to treat the rectus abdominis or include the rectus abdominis muscles in your treatments, which means you're either doing motor points, trigger points, or other Usher points along the rectus abdominis. And you're probably going to involve like stomach and spleen points, either the tonification points or the sedation points to deal with the whole primary channel. Or you're maybe even involving local points that are on the opposite side, the front opposite side of where the pain is on the back. Now, if you think about the balance method, system 3, interior, exterior, elemental pair, you've got the do channel on the back and then the ren channel on the front. So ren balances do. You've got the bladder channel, inner and outer. So kidney balances bladder. And then you've got the primary channel relationships where forward bending, right? Torso flexion, which is enabled by the governor vessel, the do, the bladder, and the kidney, right? That's the torso flexion. That's what tests the primary channels of the bladder, kidney, and by extension, the governor vessel, which is the antagonist to the ability to extend, which is balanced by, antagonist relationship between the CV channel, the Ren, and the stomach and the spleen. Okay, so you may need to treat both. But more often than not, when you get this band of pain that doesn't seem to just be resolved by, like balance method points where you're doing like lung and large intestine points at the elbow, or just distal to the elbow, or just proximal to the elbow to mirror or image the low back, right? Because the level of the elbow is the waist, right? So if you're doing it where this is the head, right? L2, L1, T12 would be this way, right? And then L3, L4, and L5 would be down here, right? So if that's not helping, it means you've got to involve the rectus abdominis muscles, which means you may go to the local area where you're dealing with CV points, kidney points, stomach points, spleen points in that band of an area in the lower dantian. Or you may be working with the primary channel itself of the stomach spleen, where you're doing the primary channel treatments where you're tonifying the tonification points because those muscles are weak. So it needs more supplementation of qi and blood as transmitted by these channels through that area, right? So you may go to the local area itself in the lower dantian, or at the level of the umbilicus, which is the level of the waist, or which is like, a local channel approach and a local tissue approach, or you may want to go to the stomach spleen channel more systemically and do the tonification points, which enable the stomach and spleen to activate that area of the body, which then balances the low back, which is in pain. Does this make sense? Because the stomach and spleen go through the rectus abdominis muscles. So if the spleen and stomach channels are getting like a nice flow of qi and blood through that area, that helps the rectus abdominis do what it does, as well
So
as
this would
sinew treatments.
So this would still be a channel approach, though. It's not the points that we're going to use will not necessarily fall directly on an acupoint on the stomach and spleen.
Oh, it might not.
Okay.
Right?
Okay.
Especially if you're in the local
just trying-
area, it may conform to a named and numbered point. It might not. Right? It might not. It might just be Ashur, or it might just correspond to the level of which they feel this pain. So like, let's say they've got a lot of pain just above their sacrum, right? This is for low back strain and low back sprain. They may feel this pain right above the SI, like where like L5, S1 meet, like they have this pain that goes across there. So if I go around to the front, I might be treating like a bunch of points along the stomach channel or along the spleen channel or along the kidney channel, some of which may correspond to named and numbered points, some of which may not, right? And so your point selection can be either you palpate the CV, you palpate the kidney, you palpate the stomach and spleen, and certain points are Ashur, or certain points call out to you, and so you do those. Or nothing really calls out to you through your fingertips, and nothing is necessarily Ashi, but that area of those channels do correspond to the area of pain on the back, so I do them for that reason.
Time. Can I ask you a question? This may be, I converted this document that you shared with us to a Google Doc, and on page 12, where you have the back sprain assessment and treatment, is there a treatment provided?
No, I've left the
Okay.
treatments off for a reason.
Okay.
Yeah.
All right. So you may have said that earlier and I just missed it. Sorry.
No, I didn't. I'm sorry. So I've left the treatments off because right now what I want to focus on is assessment and diagnosis. There's a lot of treatments, and I was realizing, like, if you guys are looking at this, your head's just going to spin. So we'll get to the treatments later. Right now, I'm just talking about it more conceptually in terms of what's going on with the local area. So in a back strain or sprain, you're dealing mostly with the muscle, with the soft tissue that may or may not, to some degree, especially more in a sprain than a strain, affecting the tendons that anchor the muscles to certain bony structures. So there's going to be certain tests that are going to be, that you want to rule out. So you want to do, anytime there's back pain, you just want to double check and test, do a straight leg raise, do the slump test. If those are positive, do the heel toe walk and the femoral provocation test and the standing stork test, right? If by the nature of where the pain is, they're pointing to what you think is the junction between the sacrum and the ilium, do the SI joint tests. I've heard Gillette, I've heard Gillet. That's page 9. So the SI joint rocking test is the easiest to perform, and if there is a problem, it's the one that's least likely to make your patient slap you. Right? It's going to provoke the least amount of pain, but it's then going to make you go, if it's positive, right? Then there's the Faber test, which is flexion, abduction, right, which is movement away from the trunk, flexion, abduction, external rotation. That's sort of like the figure 4, where you're putting, it's like if you crossed your leg, where you're putting the sole, where you're putting your malleolus or the sole of your heel, the sole of your foot on your knee, right? It's like that sort of figure 4, and then you're having them, like you have them bring the leg up like this, here's the other leg, and then you have them stretch this way, right? On the affected side. So then there's the Gillet test, right? Which is explained there, and I've also given you like a YouTube link, okay? So you're basically saying, is this a soft tissue injury? Is this a nerve root problem? Is this a facet joint problem? Is this an SI joint problem? Right? Those are like the 4 major things, right? And so what's going to help you discern is, one is there a lot of like paresthesia or radiculopathy? And if that's the case, it's either going to be a nerve root issue or a facet joint problem. In some weird cases, it may be an SI joint problem affecting the piriformis, because on about, I don't know how they came up with this figure, but they say on about 40% of patients, the sciatic nerve that comes out of the lower lumbar vertebrae and kind of conducts into like 1. So there's a branch coming between like L1, L2, or L2, L3, L3, L4, L4, L5, L5, S1, S1, S2. And these little branches come down and form like one big sciatic nerve. And in about 40% of the people, I don't know how they get 40%, it goes through the piriformis muscle. So if the piriformis muscle, which attaches the greater trochanter to the sacrum, if that piriformis muscle is overactive and clamping down, right? You know, normally it's a little bit loose, and if it's overly tightened and in contraction or spasm, it's going to pinch the sciatic nerve, and you may get some radiating pain, but you won't get it in the upper back, in the lower back, in the lumbar portion. It'll start around the level of the sacrum and radiate down, and rarely will it go below the knee. So there may be some radiating pain, but you basically just do the SI joint test, and you'll do the piriformis muscle test. And you can look online. There's also some other piriformis tests. And that'll help you differentiate, you know, this is a lumbar nerve root problem, right? From an SI joint problem, from a facet joint problem, from a, you know, piriformis problem, okay? So that's basically what you're trying to discern. And again, you know, what has happened to the patient is going to guide you, and what type of pain they experience is going to also help differentiate. Soft tissue, muscle issue, low back strain, low back sprain, it's generally going to be vague. It's generally going to be in an area. It's generally going to be achy. And if it's a severe case, maybe more into severe strain, sprain, it's going to be occasionally punctuated by a sharp pain that's brief and that kind of like maybe, you know, really catches them and inhibits their movement in some way and makes them get really stiff. But the pain won't radiate for very far. They might feel it shoot through their low back. It might even go down into their glutes or around their hip, or maybe even around to their groin. But that's generally as far as it'll go, because that sprain or strain has severely inhibited like the blood flow. So there's some blood stagnation involved, okay? And what's gonna generally give you more information about that will be the sinew meridian tests and the primary meridian tests. And then you can then go and isolate it further by doing the manual muscle tests. And you're also going to then test the posture. You're going to assess the posture, which then is going to indicate further what muscles are going to be involved based on what I've written in your notes. If they have an anterior pelvic tilt, these certain muscles are going to be locked short, shortened and overactive. These muscles are going to be lengthened and inhibited. So what do you think, what kind of intentional needle action might I do to a muscle that's shortened and overactive? What kind of needle action would I use?
Sedation.
Sedation. And so for lengthened and inhibited, I'm going to tonify. So if I'm going to do cupping, I'm going to do stronger cupping for a greater period of time for weakened inhibited muscles. I'm going to do maybe moving cupping or draining cupping techniques for muscles that are shortened and overactive. For weakened muscles, I might do, in inhibited muscles, I might do more moxa. I can do E-stim on both. So I'm going to be doing more like sort of a higher intensity E-stim for a slightly longer period of time, maybe a little more hertz for a shortened overactive muscle. And I'm going to be doing a more gentle stim, right, for maybe shortened period of time. And there's some debate about what you do longer or shorter, you know, for the lengthened and overly weakened muscle. Some people say you want to do higher intensity at shorter periods of time for shortened overactive muscles, right? Higher intensity, shortened period of time for shortened overactive muscles. Some people say lower intensity, longer periods of time for weakened and inhibited muscles. Try it out. I don't really do E-stim more than 10 minutes. You know, Lombardi says sometimes up to 20 minutes. I'm a little leery about that, but you can experiment. And you can kind of do some investigating in that yourself, okay? There's a lot written online about that. But you follow what I'm saying? So you're kind of going from like, I've got back pain, and you're working kind of your way down to the point where it's like, I know what muscles are involved in this, and I know the state of those muscles. based on the posture and based on the sinew treatments, a sinew meridian evaluation, and the primary meridian evaluation. Does this make sense? So we just have to like work it, you just have to like work it through in your mind. And I'm gonna give you a little bit of homework to do where you're gonna do that, okay? So soft tissue injuries, back strain, back sprain, generally more vague, generally more chi, maybe accentuated by some brief blood stagnation, sharp pain, gripping pain, ooh, ooh, right? There's generally gonna be more stiffness than pain, or the pain will be achy. And if it does radiate, it probably won't go past the glutes. Okay. Then you want to see, okay, you know, just to rule it out, are there any like, is there any nerve root involvement here? You do the nerve tension tests, right? And, you know, again, if it's low back, like low back, probably not radiating, or just in the general vagus area of the SI area, sacral area, iliac area, maybe into the glutes. Test the SI joint. Okay. There's the SI joint rocking test, the Faber test, and the Gillet's test. All right. So when you're dealing with a back strain, I often include cupping. I generally do it for maybe 5-10 minutes, maybe up to 15 minutes. If there's a lot of gripping quality and stiffness, I might do some moderate cupping to strong cupping and moving cupping. I put my oil down and I use my fire cups or the silicone cups and move the cup. You can even put down some kind of healing liniment, blue emu oil, one of my liniments, Dr. Scher's liniments, some kind of Ditat Chow, maybe what's the other one, Topricin or Topricin, I don't know how they pronounce it. And then you can kind of like, or just massage cream or oil and, you know, do moving cupping, right? Brings a lot of chi and blood to the area, helps to relax the back, move out any cold and wind that might be straining the back and creating a lot of stiffness. Again, that's more wind, more cold, okay? You can do some very gentle E-stim on some of the motor points, or just like some of the inner AEPs, right? The AEPs. I also, there's some other points that I'm going to include later on that are really good for back strain and sprain. These are 2 points called PGEN, P-I-G-E-N, and Yaoyan, Y-A-O-Y-E-Y-A-N. These are like motor points for the quadratus lumborum. These are great points, motor points, Ashi points in the quadratus lumborum are phenomenal and must be included for back strains and back sprains, right? And I will give them to you. But just know that for back strains, back sprains, especially if there's that pain that goes along an area, like across the back, you're gonna be dealing with the quadratus lumborum and the rectus abdominis. These are like gonna be your big ones that you're gonna treat first. And then you're gonna assess the posture, and then you're gonna include Usher points, trigger points, or motor points for those muscles that are involved. I would just pick out 1 or 2 of each. So if you've got an anterior pelvic tilt, just pick 1 or 2 points for muscles in the front and 1 or 2 points for muscles in the back, right? Maybe 1 upper, 1 lower, 1 upper, 1 lower. And that's often enough that that's often all that you'll need. You don't have to do motor points for every single muscle that might possibly involved, all right? Right? Maybe 1 or 2 in the rectus abdominis, 1 and maybe like the psoas or hamstring, a rectus femoris, right? Maybe a couple in the iliocostalis or rectus spinae, and then maybe, you know, 1 or 2 in like the glutes or biceps femoris, like the hamstrings. Does this make sense? Right? Couple in the front, couple in the back. And then you can accentuate that by doing like Dr. Tan or Master Dung points that refer to that area. And these are like your empirical points, your Master Dung points, or points that, you know, balance the channel that go through that area. In this case, it's almost always the bladder. You can also include the kidney, right? So, you know, you're going to be looking at, like, you know, you look at the meridian chart for bladder and, you know, you see like, you know, small intestine, lung, kidney, lung, small intestine, right? And then go along the lines for kidney. And then you can do some kidney points that are going to be somewhere around the elbow, somewhere around the opposite knee, right? To balance out the waist level, maybe just above for just above the waist, just below for just below the waist. Or you can reverse it where this is the head and this is the pubic symphysis. So you're doing points down there. I know I'm losing some of you, but anyway, you can work through the, right? You can work through the balance method or Master Dung points, right? And then maybe finish off on their CF. That's a really nice, that's a nice treatment.
You're not
All
losing us time. It's just that the balance stuff, there's so many options that it's like, I could just stick a pin anywhere.
Pick one, just pick one.
Okay.
Just say, for this month, everybody gets system 1, regardless. You can't miss with system 1.
Okay.
System 1 is awesome, right? Awesome.
And
If you
that's
want to
the
go
mirroring
wild,
one?
if you really want to go wild, pick system 2, then you can do either side. Then it doesn't really matter. Oh, it's hard to get to that side. Well, I'll do this side. Right? Just say, that's what I'm going to do on everybody. Doesn't matter. System 1 or system 2. Can't go wrong. With musculoskeletal issues, system 1 and system 2 are awesome. Right? What has 2 thumbs and loves the balance method? This guy. Right? All right. All right. So now, if the patient has either a bulging or herniated disc, boy, you're in for a treat. This is where the nerve compression tests are going to help the patient realize they need treatment. Right? I love these tests because it's not just you going, hey, I think this is wrong with you, and this is why you need to give me a lot of money, right? These tests make it very clear to the patient that they have a problem and an opportunity, and that they should listen to you and get your treatments, right? It's not just you making something up. Like, you have them do this, they're phenomenally weak, they're kind of embarrassed, or it stimulates a lot of pain, and that gets their attention. All right. So with a bulging or herniated disc, this is where the jelly is pushing up against the outside of the donut or has exploded and ruptured out of the donut and is pressing on either the nerve root directly, or it's aggravating the dura mater, which literally means tough mother. I love that. The dura mater literally means, it's Latin for dura, tough, strong, mater is mother, like alma mater, right? Your soul mother, right? That's where you came from, right? So, so this is creating a real problem that needs pretty frequent treatment. Some people say only once a week, but I have not found that to be, I found it to be the case where people are not going to be like your perfect compliant patients. They need to come in 2 or 3 times a week. If they're an 8 to 10 out of 10 pain 3 times a week, 6 to 8 out of 10 pain twice a week, 5 or less once a week is probably fine. So I've given you some notes about differentiation on page 12 of your notes, where under herniated disc, you'll treat it as the same as a bulging disc. If it's herniated, like ruptured, they're going to often be better lying down with something under their knees to prop up their knees. Posterior bulge, it's better sitting in extension. Anterior bulge, sitting with flexion, right? So people who like to sit up real straight, maybe even leaning back, that's a posterior bulge. They feel better when they're kind of slumping over a little bit, is anterior bulge. I've given you a lot to look at. You're going to do the slump test. You're going to do the single leg raise, straight leg raise, excuse me. and you're going to do what's called the do my percussion with Valsalva. So that's a fancy way of saying you're going to be tapping on the bones of their vertebrae while they're holding their breath. So the nerve tension tests, of which there are several, are going to give you a lot of great information. The do my percussion with Valsalva, which means they're going to be lying prone, they're going to be lying on their belly, their back is up, and you're going to like make a little mark about where their vertebrae, spinous process of the vertebrae are, and you're going to take like 3 to 4 fingers, more if you want, if they're a big person, but 3 to 4 fingers, and you're going to have them take a deep breath in, they're going to hold the breath, and you're going to tap onto, okay, great, thank you, got it. You're going to be tapping on the vertebrae, and you're not going to be just like, tap, 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 tap. You're going to be tapping pretty hard. Like if you were going to knock on someone's door and you knew they were probably doing the dishes or upstairs, like how hard would you knock, right? That's how hard you knock on their vertebrae, right? It's not like tap, tap, tap. No, no, no. It's bang, 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 bang. Okay. Okay. Right. So that is going to give you a lot. That's going to give you a sense of like what vertebrae are involved, what nerve roots are involved. It's generally the one just either just above or more often than not just below where you are knocking. Does that make sense? Gabish? Yes? Okay, good. You may need to do this by putting a pillow under their belly. Okay, so I do the nerve compression test first, the straight leg raise, the slump test, and I've given you links to look and see how they do that. The do my percussion is them laying on their belly, maybe on a pillow, and you have them hold their breath, and you tap really hard on their vertebrae, then you have them breathe, then hold their breath again, then you tap on the next one. I generally work from L1 to L5, and that's going to give you kind of a sense of what nerve root is involved. The nerve root number is the number just below the vertebrae. So like the L2 nerve root is coming out from below L2, between L2 and 3, right? The L5 nerve root is coming out from below L5, between L5 and S1. Okay?
And
nerve root pain, yes.
Sorry, will they, when we're tapping like this, will they feel radiating pain
Yes.
down following the
Yes.
line?
Yes.
Okay.
They will feel some radiculopathy. If they don't feel radiculopathy, if they feel like maybe a spreading sensation that is usually felt about 1 inch to 1.5 inches lateral, that's the facet joint. That's the facet joint. If you're doing the Stork standing test or the standing stork test, and they feel pain just lateral to the governor vessel, just lateral to the spine, 1 inch to 2 inches lateral, that's the facet joint. Right? It's not this radiculopathy that radiates down into the glutes or maybe around into the groin, right? That's the facet joints. And that's why I love the Stork standing test and these other nerve roots, because if the facet joint is damaged, they may get a little radiating sensation. And if you say, does the pain radiate? And they go, yes. And we don't say where to, right? The facet joint problem can mirror a nerve root problem. And facet joint problems are often overlooked by orthopedic docs who are no, it's not their fault. If they want to make a living, they got to see patients every 7 to 8 minutes if they're taking insurance. So they'll go radiating pain. Patient goes, yeah. Oh, nerve compression. You need this. And it's oftentimes a facet joint problem compounded by a soft tissue muscle problem, right? Which may even be compounded by a piriformis problem. Okay, so with the herniated or bulging discs, you're going to be doing spirit points, you're going to be doing Huato Jiaji points at the level of where the nerve root issue is, plus the Huato Jiaji points just above and just below. So there'll be 6, right? 3 on one side, 3 on the other. Okay? So you're going to identify what nerve root. Also, in your on Canvas and in Leggy, right at the beginning of the blue section in Leggy, I think it's, or just at the end maybe. Shoot, yeah. At the very end, the last page of the blue section, you'll see what are called dermatomes. Dermatomes of the front and dermatomes of the back. What that means is this is the area that's innervated by a particular nerve root. So if it's L3, L4, they're going to feel the pain in this specific part of the body. If it's a nerve compression between L4 and L5 and the L4 nerve root, it's going to affect this area of the body. I've included it on Canvas. I can't remember exactly where. It might be in the resources section, but I have included this image. You'll have to look for it. And this can help narrow down the area. And when you've narrowed down the area, you've narrowed down the meridians that might be involved, and you've narrowed down the muscles that might be involved. So you can do your sinew and primary meridian treatments, as well as the Huato Jiaji, then your sinew meridian treatments, and or your primary meridian treatments. Then you can go to your either motor points or trigger points. And then if you still need to, then you can go to these balance method or master dunk points that relate to those channels that are involved. You see how we're putting this together? And it's going to be a combination of distal to local. I start distal, work towards the local. And part of my distal treatments include a lot of bleeding. If there's herniated disc or bulging disc, there's a lot of stagnation by definition, right? The disc is stuck, you know, is like this bulge, this herniation is stagnating the tissue, the fluids, the tissue, the blood, the nerves in this area, right? And so there's really nothing better for blood stasis, any stasis, including spirit stasis, Shen stasis. I'm stuck in obsessive compulsive disorder. I'm stuck in anxiety. I'm stuck in fear. I'm stuck in the echo of my previous trauma. Bleeding, nothing better, nothing better. If you remember nothing from this course, if you just bleed the points I tell you to bleed, man, you'll help people 50%. And people will feel this pressure relieved from their body and their mind when you bleed. And so what I do is I cup the area, I give it a little bit of mild suction for maybe 2 to 3 minutes. I take it off, I put the cup back in the pump, I bleed the area like with a lancet or a bleeding needle, put the cup back on, a little more suction, and I bleed that. 1/4 teaspoon, 1/8 of a teaspoon, maybe as much as a teaspoon. You know, the more severe it is, the more I bleed them. The more qi deficient and blood deficient they are, the less blood I take out. I've never overbled somebody. Because again, they may have this deficiency because of the stagnation. If you don't move the stagnation, they can't build qi. Okay? I'm adamant about this, as you can tell. So, bulging herniated disc, nerve root compression issues, bleeding, sinew meridian treatments, right off the bat, really helpful. Akabanis, sometimes, you get a nice result. Not so much. Akabani's better with soft tissue issues. Bleeding, sinew meridians, then I check the primary meridians. I redo the meridians, primary meridian tests. If they're better, great. If not, I then treat the tonification points. If there's a lot of gripping, stagnating pain, the tonification points may not do the trick. You may have to go to the sedation points, right? So again, if it's like bending forward, that's really hard. That's bladder kidney. So I might need to do the Wood points, the sedation points in bladder and kidney, right? That's kidney 1, and then bladder 65, sedated, all right? And then if they're still like experiencing a lot of problems, then do like the motor points or trigger points. And then if it's still bothersome, then I add in like the Master Dung points or maybe some channel balancing balance method points. And I will give you these points. I just didn't want to focus on them today because they'll really make your head spin. I don't often do cupping with a ruptured disc unless there's also a large amount of concurrent cold. And then I might do some very gentle cupping on the muscles, but not too close to the spine. I don't want to aggravate that nerve root. I'll do some very gentle cupping. You can do E-stim on the Huato Jiaji points, and here's how you do that. So actually, let's do it this way. So here's the spine. Here's the dew line. Here's like L2, L3, L4, L5, and then the sacrum, okay? The Huato Jiaji points are just to the side of that, right? And then here's the inner bladder line. So here's the Huato Jiajis, right? Okay, you follow me? Okay, so you're gonna have a needle, and I would get like a 2-inch needle. Now I put these straight in, okay? I have it angled for the purpose of the illustration. But what you can do is with these needles, actually you can probably see it better this way, right? That's the handle part. What you can do is you don't want to cross like black and red across the dew line. You don't want to cross the spine with that. So what you can do is you can bend these two together, right? So you can bend them so they're like, they look like this. So the needle's in like this, and you can bend it up this way. So here's the point, here's the handle, here's the point, there's the handle. If it's a long needle, you'll be able to bend them towards each other. And this is where I clip the alligator clip. You see what I'm saying? I'm bending the needles together and clamping it like that. So you would have the black here and then the red here. Does that make sense? Anterior and superior is black. Superior, inferior, and posterior is red. The red's the positive. Okay? And so you can do like maybe 4 of them, or like just 2 like above and below, and then maybe on the other ones, you know, maybe just do some E-stim like with that, and maybe like a motor point on these 2, right? Like the other 2 leads, because they're in pairs, right? Does this make sense? So you would bend the needles together and clamp them that way. And so there'd be like black and red. And you could do the black and the red just above and below, or or do the positive, the red, at the level of the herniation or bulging. Does that make sense? So that's a way you can do e-stim on these. Very helpful, very helpful. SI joint pain, just very briefly, I wanted to mention, like with SI joint pain, there's a way you can, you know, this is, again, there's going to be, I've given you the assessments, right, on your page 14. There's 9 ways of assessing this. This is not rocket science. This is not rocket science. This does very well with cupping. You can cup over the sacrum, over the SI joint, so you can have cups along the sacrum, foramen. You can have cups along the superior ridge of the sacrum. You can have cups along the inner bladder line, down the side of the sacrum. This helps to move a lot of cold. This really suffers a lot from cold and wind, rarely from heat, more often like wind cold or wind cold damp. So the cupping is really useful. And then you can needle into the sacral foramen, as well as especially needle at a 45-degree angle laterally. So here's the sacrum. You angle your needles laterally into that, where you feel that crease between the sacrum and the iliac, in the SI joint itself. You can kind of 1.5, 2-inch needles. If they are super sensitive, just needle at the surface. That's enough to get chi and blood moving through that area. But for some people, you can needle into the joint, and you can do e-stim there, or moxa on the needle. If you're going to do both, I recommend not doing both and just taking turns with moxa on the needle first and then trying the e-stim later. Because the moxa is the more gentle treatment, and that may be all they need. And it's just a fabulous treatment. And then while those moxa are burning, or while the e-stim is going, you can do distal points that are either Master Dung points or, you know, or Dr. Tan channel balancing points that balance the sacrum. And so what balances that SI joint is the joint between the lateral part of the scapula and the like the, I don't know, whatever that's called, like around the head of the femur, head of the
acromion.
Huh?
The acromion.
Yeah, like the acromioclavicular joint, right? Around like small intestine 10, and then back along that outer edge of the sacrum. I mean the scapula, because the scapula together mirror the sacrum, right? So the SI joint would be like really close to the bone along the outer edge of the sacrum. You can do like 1.5, 2-inch points, like feel for where you feel the edge of the scapula is, and then go just a little bit in, because, you know, there's tissue there. So it's gonna make it seem like it's further lateral than it is. And you can needle right along that edge of the sacrum, of the scapula, and then right up into that like scapular joint between where the clavicle and the acromion and the head of the humerus and the scapular spine all come into play, like a little bit lateral to small intestine 10, like in small intestine 10 and thereabouts. You can get like right in there. So nice. Really helpful. And you can do that same side or opposite side. I understand you're feeling overwhelmed. I get it. But again, I'm just introducing this stuff to you, okay? I've mentioned some stuff about arthritis, right? And facet joint injury. Just read over that. And then next class, we're going to be talking about the hip and then how to treat the hip and lower back. So I'm going to offer an assignment probably in, I don't know, it'll either be in the assignment section or the discussion section, but I'll make an announcement about it either way, just to have you practice a couple of these orthopedic evaluation tests and combine that with some primary and sinew meridian tests on yourself or others to kind of get a sense of what might be going on, if there is something going on, right? But just to get it in your body, just to try them out. I know it's overwhelming because the back is very complicated and there's a lot to it, but I guarantee you, if you follow my step-by-step instructions about how to progress through your questioning, through the questions you ask, and through the orthopedic evaluations and the sinew meridian tests and the primary meridian tests, you'll find out which one is the most aggravating out of all of those, and that's what you treat first. Whatever provokes the most pain, whatever provokes the most discomfort, whatever inhibits their function most, that's what you do first. And we'll talk more at the end of the course about integrating these treatments with like real cases, okay? So we'll do some case studies, and we may even do some work with you guys. And if I can manage to do this with a patient, I'm gonna have a patient come in and work it out over Zoom. If I can, it's been challenging. All right, so I'm sorry I've been 3 minutes over, but if you have any questions, like don't worry about the overwhelm. It's natural, it's normal. There's a lot of information here. I get it. The back is super complicated, but just read through the notes a couple of times. Read through the notes a couple of times. Go online, look at the tests, right? Just get a sense of the basic anatomy in terms of the posture. And I guarantee you, when you start to apply this, only then are you gonna go, oh, now I get it. Until you start to apply it, it's gonna be in this vague cloud. So don't worry about that. Just get a sense of like the overall like scheme of things. Nerve root compression, soft tissue injury, back sprain, mostly involving the quadratus lumborum or the rectus abdominis, SI joint problem, facet joint problem, okay? Those are your main issues. All right, have a great one. Thanks for hanging in there.